So thank you so much. It's a really, really pleasure. Thank you, Prof. Stephen and Dr. Hab for the opportunity to come here and meet teachers and friends and colleagues for some time back. It's been about 12 years since I left Kenya after my residence. So time just flies all over. And I have very, very fond memories. Prof. Ndwati, Prof. Irim, they had to force me to go this journey of pediatrics, and now here I am, so I appreciate. The question I was given is one that is difficult, and it's equally going to stimulate a bit of discussion. And I will do get a bit of insight. I appreciate Evelyn being here as allergy specialist, so it's quite an interesting. We all in our practice, especially those who still have the opportunity to be in private practice, get these questions relating whether our children or babies who are still breastfeeding can actually have allergy. And it's a difficult question, at least for me and in my practice. And so that's what we are going to see briefly. So that is the outline, and it's very, very basic, but very, very important, because one of the reasons that even formulas are still on the market is that sometimes we are convinced that breast milk in one way or the other has some detrimental effect, especially when it is branded to have an allergy or something related to that. And so we will try to see what evidence that there is. So first of all, we do appreciate that the topic of allergy intolerance to breast milk has lots of controversies in both in literature, but also in our clinical settings. And that does not take away that breastfeeding is the optimal source, as we saw that, and I don't want to emphasize that. We all know it. I think what we were challenged is how is our practice impacting into that in the larger scale of our communities and our practices. However, the evidence still indicates that at some point we need to be aware as clinicians and be informed so that we can appropriately guide breastfeeding mothers. So it is absolutely rare in terms of saying that when allergy or intolerance is clinical relevance where we need to take action is quite rare, and the evidence is limited. So we need to appreciate that, but we need to do that in the context. The reason I'm emphasizing that is that it's more commonly spoken about than actually it is a clinical subject to be mindful and to do something beyond we are supposed to do. And so the same applies. The reason for the controversy is that there is some evidence that there is some, even if in smaller quantities of allergens that are detectable in human milk, which cause or that is related to the infant with allergic symptoms. There is evidence that skin prick testing, these are not very randomized world class, but these are case series that are documented. And I summarized the evidences that we can go. Actually, European Allergy Society has very good recommendations on that if somebody has time to do that. And we can always discuss the relevance and applicability in our setting. Nonetheless, there is evidence that skin prick testing on breast milk collected from maternal who have been exposed to these different allergens, especially the more common is the cow's milk as we know it, but also the other allergens pass it through the milk and have shown to react or become positive in sensitized infants who have experienced such symptoms during their breastfeeding period. So it is critical to examine the evidence for and against any form of food allergy elimination when you're going to eliminate any form of diet from the mothers, meaning that you have to be aware that these are rare cases, these are not very many cases, and they have to be dealt by individually and not generalized because of the facts that have been highlighted. So we do, and absolutely we, so we do there are some clear evidence that are current that food antigens do exist in human milk. They pass through the human milk. The only challenge and the difficult scientific question is that not every mother will do it at the same time and in the same quantity, and then becomes a little bit complex for researchers to delineate actually to what extent the problem is. And one study showed that 1 to 2/3 of mothers appear to secrete dietary food proteins into their milk. And as I mentioned, the levels do not necessarily correlate with the symptoms or the severity of the symptoms. Neither do all mothers individually have or secrete the same quantities. And that's very important, becomes complex to do that. The same applies to the manifestation of symptoms, and here we're talking about whether it's IgE or non-IgE mediated allergies. The ER reports definitely of food protein excretion into human milk appear almost as old as a couple of centuries ago, but to delineate the extent of the problem on how actually the allergens that are in breast milk manifest clinically and cause the clinical manifestations we see, that's where the caveat lies, and that's where having adequate knowledge is important for clinicians to be able to appropriately guide families and parents. And therefore, what I wanted to highlight here is that in many circumstances in our practices, you see parents and healthcare providers, these common symptoms are always attributed to allergy. And the reaction is that we do something. We either remove some food from the mother's feeds or diet, or we ask even the mothers to take the absolute alternative to advocate to promoted or marketed brands that are thought to be non-allergic or hypoallergic products. But the consequence could be that one that I mentioned, restriction that is unnecessary in many cases, and to some extent we need to correlate the evidence that you have. The SAMs will talk about a little bit on the diagnosis and how we formulate that. I looked at this systematic review, and what I wanted to highlight, even if I mentioned, is actually, does the pointer work? No. Okay. Yes, it does. So I just wanted to highlight the numbers, the 1% of allergic individuals across the samples that started. And the estimation with these 32 different studies, the estimation was that actually relevant food can be estimated to be 1 in 1,000. So we can imagine, I don't want to minimize the problem. The problem is there, but when you truly look on a few studies that is done, it's not a big problem that we need to be addressed. But we need to know because it causes anxiety in the breastfeeding mothers. Okay. The pointer is a bit slow. Okay. I will not delay much on these symptoms. You all know them. The questions whether there is anaphylactic reaction is possible, and the answer is yes, but these are extremely rare cases that has been reported in the literature. What about atopic dermatitis? Absolutely yes. The studies are limited, most of which are not based on general population, so center-based studies. However, the overall prevalence is low, and most infants with allergic symptoms do not have cause to do that. What do I need to mean here? When you read the literature, is that most of those children who have one sort of skin reactions, allergic skin reaction, do not necessarily mean that they have allergy to food proteins into the breast milk. What about the more complex and more clinically relevant food protein-induced allergic proctitis? Still, yes, but when, again, I want to highlight this reality, to highlight, this is a report, very good, one of the bigger reports. There are not many, to be honest, in the literature when you read through, but 70 cases, 41%, 53% of whom were breastfeeding at the time of symptoms, found that 8% of infants reacted to alone. So what this means is that cow's milk seems across to be the major culprit. Nonetheless, the other allergens can also be part of that. But I wanted also to say that about 20% of breastfed infants with this have concomitant other signs and symptoms. So to be aware that it may not show as one sort of symptom, but rather quite a number of spectrum of symptoms. Also, the same applies to another case report of 27 patients with enteropathy syndrome. Second to that, 22% of tests were exclusively breastfed. Out of those, and a proportion of these cases showed improvement in the restriction of maternal diet alone. So these few cases and case series, I don't know how it keeps pushing, but they pertain, I don't know why it is praying, but the whole point is here that it is true we can get these conditions, we can get some few children reacting to the allergens into the breast milk and manifest with these symptoms. But we need to not necessarily be extremely aware and appropriately guide the families. The same applies to non-IgE, which we know that it takes longer, and that's the difference. The IgE associated mediated from the allergic classes that we know is that it will manifest immediately after you get exposed to the allergen. But here with non-IgE, it takes time. And for the few babies or children that have that, will manifest with long-term a bit of signs and complications, and we need to be aware. Again, the numbers are very small. This is a number from the European large study where they said it was around 1%, and in the UK was around 2.4%. And the majority of the culprit was still a cow's milk, as we have seen. However, the true prevalence is thought to be higher and is frequently. This is questionable, whether it is higher or low. The whole point is that these are limited studies to make a large inference on a large community. The symptoms are well known. I don't need to go into that, especially the symptoms that are associated with non-IgE symptoms. So they are quite those that we talk about or we face in our practices. The last important question before we go to the management and approach is, can babies have allergy to their own mother's breast milk, even if you removed everything else? And the answer is yes. There are few limited studies that have demonstrated that babies can still have some allergic reaction to their maternal milk. And there is quite a good study that I quoted here where they showed there is absolutely some cross and relationship between proteins on the maternal breast milk and the bovine or cow's milk or the other source of milks that we do. So these, we have to be aware. We do not have to be to be really close into that, but there is cross similarity, and therefore babies, very extremely, very rare condition, but they can still have quite strong allergy reaction to their own mother's breast milk. And so that's what I wanted to make, and we have to be aware and do the right thing once we meet some similar circumstances. So as we wrap up making a diagnosis, this is where the experts, the breastfeeding consultants, the dietitians, and the allergy specialist comes in, because it's complex to sit down and take an accurate focused history, which is the foundation, other than there is no quite validated biomarkers to support that. And the cornerstone for either diagnosis across the literature that looks there, which type we have is that you try to do elimination trial for 2 to 4 weeks and then reintroduce and see if the symptoms recur or they worsen in one or the other. So this is the cornerstone because the diagnostic tests are quite very limited. So the diagnostic elimination that should ideally be implemented with the support with a person who is clinical at this. And this is difficult within our OPD settings and the correlation. Nonetheless, the whole mark is that we have to be absolutely aware of the limitations of what we do and make sure that we promote optimal management. These are nutritional considerations that we mention absolutely. What I need to highlight here is that by no means does the maternal diet have to be perfect. However, eliminating multifoods can do. And I think many of us knows that the breast milk is and correlates with the nutritional aptness of the mother. And we have to be aware when we start doing elimination or restriction of diet based on the allergic symptoms of the infant. And ensuring that adequate substitutes or supplementation to maternal diet is very essential to the quality of the nutrition of the mother, but also of the breast milk and the baby in that regard. The last, this is the second last, is intolerance to lactose. And that is also another controversial field and area of that. We know that lactose is the major sugar in in the breast milk and many bovine, especially mammals, and we get it everywhere. But I want to highlight that there are mainly about 3 types of lactase deficiency, which causes lactose intolerance. The congenital one is extremely rare, and the one that we should be worried about. That's where extremely because of genetic anomaly, that enzyme is not able to produce. And that is what worries us. The primary and the secondary is what we face on a transient aspect in the society and in the community. So for the purposes of breastfeeding, this is more relevant, and that can be associated with quite significant clinical impact. And the only option, those are the rare cases where breast milk has to be eliminated from the diet of the baby, and we have to be aware. Only so far, I saw a paper that said only 40 cases have been reported. I would be interested to hear if there are some people who have made cases, but this is an interesting aspect of that. So to summarize, given the accumulating evidence, reaction to proteins into maternal diet delivered via human milk may be less rare than one thought. However, most reports are small and come from referral centers, resulting into uncertain prevalence estimates across. And the goal should be to minimize unnecessary elimination diets, and approach should always be guided by stability and growth of the infant in that context. So, and the knowledge of understanding the problem. On contrary, I want to highlight this. Data indicate that our introduction of food allergens had beneficial effect, and especially when it is passed through breast milk. So the last point is the take-home message, is actually that exposure to the allergens is more protective than adverse in promoting breast milk. And thank you so much for your attention.